Hello everyone, my name is Shannon Maher and this will be my PowerPoint presentation on viral enteritis. I will be starting more broad and working my way down to types of enteritis that affect adults, specifically viral, but I just want to start a little bit broad to get a better general understanding of gastroenteritis as a whole. So in the United States, it is responsible for over 500,000 outpatient visits annually and at least 60 documented deaths annually. It is often labeled the stomach flu. It is typically a self-limiting inflammatory disorder affecting the stomach and small intestine, characterized by 3 or more loose or watery diarrhea within a 24-hour period. Etiologies behind gastroenteritis include bacteria, parasites, viruses, toxins, and drugs. The viruses are responsible for 75 to 90% of cases. The acquisition of gastroenteritis may be foodborne, waterborne, person-to-person, direct contact through fecal-oral transmission, and occasionally through zoonotic spread. Acute gastroenteritis is the leading cause of morbidity and mortality worldwide. It remains a leading cause of infant mortality and leaves the elderly and immunocompromised at high risk for severe disease and associated complications. Moving on to acute viral gastroenteritis, it is typically seen in 3 clinical settings. 1, sporadic gastroenteritis in infants, where 35 to 65% of cases are caused from rotavirus. 2, epidemic gastroenteritis, and 3, sporadic adult viral gastroenteritis. The majority of cases of epidemic viral gastroenteritis are caused by the calicoviruses, 2 of which affect humans, norovirus and sapovirus. Other causes may include rotavirus and astrovirus. The causes of sporadic adult viral gastroenteritis have minimal associated studies. However, epidemiologic evidence points to norovirus as the most common etiology, followed less commonly by non-group A rotavirus, astrovirus, and adenovirus, respectively. For purposes of this presentation in relation to taking care of young to middle-aged adults, material will focus on the most common virus causing gastroenteritis in the adult population, which is norovirus. Norovirus is an enteric viral pathogen that is responsible for significant morbidity across both community and healthcare settings. Previously known as the Norwalk virus, it was the first viral agent identified in the etiology of gastroenteritis during a 1968 outbreak of gastroenteritis in Norwalk, Ohio. Prior to this discovery, illness suspected to be associated with this pathogen was referred to as winter vomiting disease, named aptly for its seasonal winter presentation associated frequently with vomiting. Norovirus remains the leading cause of epidemic gastroenteritis in all age groups, responsible for an estimated 685 million cases annually, accounting for 18% of gastroenteritis worldwide. Within the United States alone, norovirus is also the leading cause of foodborne illness, contributing to nearly 5.5 million cases annually. Norovirus specifically is spread through fecal-oral transmission, either from direct person-to-person contact, exposure to foodborne or waterborne contamination, or to infected aerosols produced by vomiting. Norovirus is unique in its ease and effectiveness of transmission, related to the small number of particulates required to produce infection, which is less than 100 particles. Viral shedding that may persist for weeks despite a lack of symptoms, and its distinct survivability. Standard household cleaners and alcohol-based disinfectants will not remove norovirus from surfaces. Bleach is required to do so. It has even been likened to a shapeshifter, continuously evolving through recombination and mutational events in response to the evolutionary pressures of the human immune system, having created at least 6 genogroups and over 40 genotypes, 3 of which are known to infect humans, which are G1, G2, and G4. Despite its typical self-limiting nature in healthy individuals, norovirus infections can be severe and life-threatening in immunocompromised individuals, young children, and the elderly. Its ability to cause global outbreaks through foodborne infections remains a worrisome international risk, and its evolutionary nature complicates containment and possible vaccine development. The Norwalk virus agent, made up of 27 Newton-meter virus-like particles, is depicted in the top left-hand corner of the slide, was first visualized using immunoelectron microscopy. The pathogen was later identified as being part of the Calicoviridae family, composed of a small single-stranded positive sense RNA genome, about 7.5 kilobases in length. The norovirus genome contains 3 open reading frames, encoding for a large non-structural polyprotein made up of 6 proteins, which is ORF1, a major structural protein, VP1, which is ORF2, and a basic structural protein, VP2, which is ORF3. VP1 and VP2 form a capsid that encapsulates the norovirus genome up until the point of human exposure, whereupon VP1 binds to histoblood group antigens, HBGAs, which are glycans expressed on the surface of specific host cells present in saliva and other body secretions, where the capsid can then be internalized, uncoated, and disassembled, allowing for positive RNA transcription and translation within the cytoplasm of the host cell. A resultant genome replication transcribes positive RNA into negative sense RNAs, which become the building blocks for the synthesis of new subgenomic and genomic positive RNAs that continue producing VP1, VP2, and new virions, respectively. New viral material is then released from the infected host, although the mechanism behind its release is not yet known. The pathogenesis and severity of norovirus infection is characterized by the pathogenicity of the specific viral genotype, host cell tropism, and individual susceptibility to said genotype based on individual HBGA makeup. Additionally, bacteria in the host microbiota may play a role in the severity of norovirus infection by modulating host immunity and providing HBGA-like sugars to support norovirus attachment, where replication in this setting is further supported by B cells. There's a lot going on. Intestinal biopsies display villus blunting as part of norovirus pathology, where the illness causes intestinal villi to become flattened. In immunocompromised patient, this finding is associated with increases in both apoptotic epithelial cells within the duodenum and intraepithelial lymphocytes. In healthy individuals, villus blunting is seen within the jejunum alongside infiltration of lymphocytes and monocytes. These findings in association with biopsy cultures from infected individuals has helped outline the pathologic disease process associated with norovirus, showing that infection creates epithelial barrier dysfunction by increasing the number of cytotoxic intraepithelial lymphocytes and apoptotic epithelial cells. Decreased brush border enzyme production is directly related to the interference caused by virus replication and its utilization of enterocytes to do so, leading to malabsorption and osmotic diarrhea, which is further progressed by transudative fluid losses into the intestine due to the flattening of intestinal villi and the cell lysis of enterocytes. Illness and transmission associated with norovirus varies depending on age, immune status, seasonality, and exposure. Norovirus illnesses and outbreaks are seasonally and typically occur during winter months. Norovirus has been associated with high-profile outbreaks due to its ease of transmission. High-risk settings associated with norovirus infection include healthcare facilities through nosocomial transmission, food service settings, nursing homes, schools, childcare settings, college dormitories, and cruise ships. Norovirus is referred to as the cruise ship virus due to high rates of infection related to diarrheal diseases on cruise ships, although this accounts for a very small number of norovirus infections actually, but it just gets a lot of media attention and it spreads very quickly. Controlling norovirus on a cruise ship is especially difficult due to shared dining spaces, close living quarters, a population consistently disembarking and then returning, and having potentially infected staff remaining on board, especially when combined with the difficulties of removing the virus from surfaces. It's difficult to bleach an entire cruise ship, right? Outbreaks of foodborne norovirus occur most often within food service settings. Most often it's seen through the hands of infected food workers touching ready-to-eat foods prior to serving them. Although, as we know, with infection and poor sanitation practices, any food can become contaminated if it has been handled with infectious hands, even after being cooked. Outbreaks also occur directly from contaminated food at its source or by sewage-contaminated water, so like at the farm, Foods that are most commonly involved in norovirus outbreaks include leafy greens, fresh fruits, and shellfish, such as oysters. In the U.S., the elderly have the highest risk of mortality from gastroenteritis. Due to advanced age alone, infection with norovirus is likely to be more severe and have a longer duration. Norovirus outbreaks within nursing homes place residents at high risk of gastroenteritis-related aspiration and pneumonia, the most frequently reported mortality causes associated with norovirus. Evidence also associates the incidence of norovirus in this population with sepsis, colonic perforation, necrotizing enterocolitis, cardiac complications, malnutrition, and acute GI bleeding, although these are less commonly reported and even less so more commonly reported in association with norovirus. Immunocompromised individuals risk chronic infection with norovirus, especially in transplant patients, those receiving immunosuppressive therapy and or chemotherapy, patients with congenital immunodeficiencies, and patients with HIV. Functional and healthy adaptive and innate immune systems clearly seem to be important in effectively clearing the virus from the intestine and intestinal lymph nodes. The clinical manifestations of acute viral gastroenteritis typically follow a predictable disease process, although the spectrum of disease has been shown to have a range varying from asymptomatic infection to death following complications with comorbid conditions and or dehydration. The disease process is usually self-limiting for healthy hosts. A 12 to 24 incubation period for norovirus is often followed by a short prodrome consisting of low-grade fevers and vomiting. This vomiting has been hypothesized as being due to delayed gastric emptying as a result of abnormal gastric motor function. Those prodrome symptoms are often followed by watery diarrhea that may last 1 to 4 days, and that may additionally be associated with anorexia, malaise, headache, myalgias, mild abdominal pain, and or abdominal tenderness, generalized. Nausea and vomiting may persist, but normally resolves with the onset of diarrhea. The rapid onset of vomiting can be used to clinically differentiate viral from bacterial and protozoal-mediated diarrheal diseases. The duration of diarrhea associated with norovirus is typically shorter than that of other enteric infections, where the duration of norovirus typically subsides within 1 to 3 days. In severe cases, severe dehydration related to persistent fluid losses may cause hemodynamic instability, organ dysfunction, and death. A diagnosis of viral gastroenteritis is likely with the presence of previously listed clinical manifestations in the absence of alarm findings. The presence of alarm signs and symptoms may indicate bacterial infection or other diseases requiring urgent care. Warning signs indicative of bacterial infection include high fevers, bloody or mucoid stools, severe abdominal pain or tenderness, or greater than 6 stools in 24 hours. Other alarm signs and symptoms include those representing severe dehydration, which will be discussed on the next slide, symptoms that last greater than 1 week, patients who are above the age of 65, who are immunocompromised, and those who are pregnant. In addition, a diagnosis of viral gastroenteritis will be void of an alternative diagnosis suggested through subjective data collection like travel history, occupational exposure, sexual practices, or antibiotic use. Physical exam findings, most specifically upon abdominal examination, may demonstrate mild generalized abdominal tenderness, hyperactive bowel sounds. Patients might have a slightly elevated temperature, although as we know, true high elevated temperatures is an alarm sign. This temperature, might be associated with sweating, diaphoresis, redness in the face. Patients might also present as pale, green, nauseous appearing. The consistent fluid losses associated with vomiting and diarrhea may lead to varying degrees of dehydration. A thorough physical exam is necessary to assist in assessing the severity of dehydration and resultant treatment. Severe dehydration will exhibit poor skin turgor, dry mucous membranes, skin tenting, absence of tears, capillary refill of 3 seconds or more, allegoria or anuria, maybe dark-colored urine, and hemodynamic signs of dehydration include tachycardia, a 30 pulse, and hypotension. Elderly patients additionally may present with mental status changes related to alterations in circulation. Listed here are the various differential diagnoses that can accompany the clinical manifestations associated with viral gastroenteritis. The typical symptoms obviously can be associated with so many different diagnoses, and it's the presentation and process of the disease, of the manifestations as a whole, is where you get your diagnosis. But while it does follow a consistent clinical disease process for the most part, it is important to rule out these differential diagnoses that may be associated with more severe disease. I think it's easy to poo-poo, viral gastroenteritis in a patient, but we have to be careful because of all of the differentials that it potentially could be. And now we get to our diagnostic criteria. Aside from, clinical, it's clinical picture, because, a clinical diagnosis is a diagnosis is pretty much made clinically based on subjective symptoms, physical exam, exposure history, absence of alarm signs and symptoms, alongside findings that coincide with gastroenteritis as well, which could be, ingestion of untreated surface water, potentially contaminated food, or a known gastrointestinal irritant, recent travel or contact with infected people. Upon initial clinical manifestation of diarrhea, the Infectious Disease Society of America, ISDA, recommends gathering a detailed clinical and exposure history following jurisdictional recommendations regarding outbreak reporting and infection control procedures for those who attend or work in child care centers, patient care facilities, long-term care facilities, recreational water venues, or the food service industry. Due to the self-limiting and generally good prognosis associated with viral gastroenteritis, given that hydration status is maintained, confirmed diagnosis through various diagnostic procedures many times will not change the trajectory of disease process or treatment modalities. Specifically, clinical practice guidelines proposed by the ISDA for diagnosing and managing infectious diarrhea do not recommend diagnostic testing or empiric antimicrobial therapy for those with acute watery diarrhea in the absence of recent international travel, unless diarrhea has lasted longer than 13 days, and therefore may be associated with bacterial gastroenteritis or more serious diagnoses. Exceptions include young infants who are ill-appearing and for immunocompromised individuals. They should probably get a more thorough workup. The likelihood of isolated norovirus infection is low due to its highly transmissible character. Although diagnostic testing for norovirus on an individual basis is not recommended, given that the individual is healthy, of young to middle adulthood, and does not display any alarm signs or symptoms, rapid and accurate identification of norovirus is essential in creating effective infection control. Viruses should be the assumed etiology of acute gastroenteritis. When vomiting is prominent, the incubation period is at least 15 hours, and the duration of illness is less than 3 days. Kaplan's criteria for rapidly identifying norovirus outbreaks was developed in 1982, prior to the introduction of molecular methods, and is still used today. The 4 criteria to be inclusive of a norovirus outbreak includes 1, vomiting in more than half of symptomatic cases, mean incubation period of 24 to 48 hours, mean duration of illness of 12 to 60 hours, and no bacterial pathogen isolated in a stool culture. Therefore, in alignment with diagnostic criteria, the optimal specimen for clinically identifying norovirus in the presence of infectious diarrhea is a diarrheal stool sample. Maintaining specimen quality through proper collection and handling is imperative for accurate diagnosis. This involves collecting specimens within closed containers within 48 to 72 hours from the onset of symptoms, and maintaining refrigerated temperatures of 4 degrees Celsius prior to testing. Confirming diagnosis in high-risk populations in order to rule out differential diagnoses and better guide treatment and monitoring should be given high priority. While stool cultures for accurate diagnosis may not be imperative for the healthy, low-risk individual without alarm signs and symptoms, stool cultures should absolutely be obtained when clinical manifestations of diarrhea are associated with alarm signs or symptoms, or when associated with outbreaks. According to the ISDA, patients who present with high fever and/or bloody diarrhea should be further evaluated for enteropathogens, for antimicrobial therapy may be necessary. Individuals that only present with fever should similarly undergo further clinical evaluation if they have a history of travel to areas with which causative agents are endemic, have possibly consumed contaminated foods, or have had laboratory exposure to enteropathogens. Stool may also be tested for white blood cells, ova, and parasites to further isolate diagnosis. While these tests are rarely indicated, molecular methods have become the gold standard in clinical virology and can assist in diagnosing the etiology of gastroenteritis. Stool antigen tests and virus-specific enzyme-linked immunoassays for serum antibodies are able to identify norovirus, and PCR testing on stool samples can rapidly identify a spectrum of causative agents that may be associated with diarrheal illness, including norovirus. RT-PCR is the gold standard for identifying norovirus. Although considered to be the gold standard, limitations in RT-PCR testing exist due to the diverse and evolutionary nature of norovirus genotypes. Multiplex PCR, RT-PCR, has emerged to include testing for gastrointestinal pathogens and has been found to be more sensitive and specific than real-time RT-PCR. Okay, I got a little confused with the recording there. In addition to stool cultures, the ISDA recommends obtaining blood cultures from infants that are less than 3 months of age in the presence of septicemia with systemic manifestations of infection or with suspicion of enteric fever in high-risk populations, and from individuals with a febrile illness of unknown origin who have travel or traveler exposure to enteric fever endemic areas. While serologic testing is not recommended to determine the etiology behind possible infectious diarrhea or enteric fever, it may be clinically useful in quantifying the degree of associated dehydration related to secretory diarrhea and insufficient rehydration, as well as assessing renal function in order to more adequately guide treatment approaches in elderly patient populations and or populations that have cardiovascular or renal complications. Dehydration can cause acute kidney injury, manifesting as increased BUN and creatinine, or electrolyte abnormalities that may progress to acid-base disturbances, cardiac dysrhythmias. Serology may additionally show leukocytosis in infected individuals. Keep in mind, however, that the irritation and inflammation of the virus alone, especially in combination with vomiting, is likely to rise leukocyte count without true bacterial infection. Other serum inflammatory markers may also be slightly elevated, including CRP and or ESR. There are no specific findings associated with imaging for viral gastroenteritis, for most abdominal studies will appear normal, while CT scans may reveal mild diffuse colonic wall thickening or generalized inflammatory bowel changes. This is not diagnostic, and therefore imaging should only be considered when ruling out more serious conditions listed in the differential diagnosis. Of course, we try to avoid radiation. So if it's following this clinical picture, that could be, viral gastroenteritis without alarm signs and symptoms, immunocompromised elderly, children, avoiding imaging is the recommendation. Reduced osmolarity and oral rehydration solution, a balanced glucose-sodium solution such as Pedialyte, is recommended as first-line therapy of mild to moderate dehydration from acute and or severe diarrhea with or without vomiting, as proposed by the ISDA. Isotonic intravenous fluids, such as laxated ringers or normal saline, should be administered in cases of more severe dehydration, shock, acute mental status, and failure of oral rehydration until perfusion, hemodynamic status, and mental status normalize. Treatment with antimotility agents like Imodium or Lamodal and or antiemetic agents like Zofran or Phenergan should be considered for symptom management. Additionally, anti-secretory agents like Pepto-Bismol can be effective in cases of secretory diarrhea in order to reduce complications associated with dehydration and electrolyte abnormalities. According to the ISDA guidelines, anti-diarrheal agents are not recommended for those under the age of 18. Instituting probiotics may additionally help replenish healthy bacterial flora. Circulating studies do report some successes with immunoglobulin treatment in chronic viral shudders, as well as resolution of clinical symptoms in chronic infection with the use of antivirals, including the use of these drugs listed here. Hard to pronounce. However, enhanced research is required for both treatments. Another treatment strategy for immunocompromised patients requiring close monitoring and an individual approach may be reducing, temporarily discontinuing, or changing immunosuppressive therapy in order to clear norovirus infection. Continuing conservative therapy based on some recommendations include continuing an age-appropriate diet as soon as possible. The brat diet is actually no longer recommended. Solid foods should be reintroduced within 24 hours of diarrhea onset. Due to persistent diarrhea and potential perineal irritation associated with that, sitz baths, hydrocortisone creams, zinc oxide creams, or witch hazel pads can provide some relief. As I've gone over multiple times, infants, elderly patients, immunocompromised individuals should be closely monitored due to their risk of more severe and prolonged infection. Clinical assessment of dehydration in every patient is imperative. We should monitor their oral intake or urine output, make sure it's correlating. be aware of any significant weight loss and physical exam findings. In addition to those measures, patients should be, at this point, they're probably really not feeling well. They want help. They want this to be stopping, right? Patient education of the disease process is super important, just to highlight the self-limiting nature of the process. Stress non-pharmacologic methods that they can do at home. Rest, conservative hydration as tolerated, given that hopefully vomiting has subsided, and then educate on preventative measures toward decreasing further spread, washing hands, staying away from family members. Proper hygiene is essential in helping reduce further transmission. Patients should be aware of the importance of bleach in cleaning surfaces in settings of outbreak, and proper food safety practices should be discussed. Ensuring fruits and vegetables are washed thoroughly, and foods containing meats and eggs are fully cooked and maintain proper temperature control. In addition to hand washing, healthcare professionals should maintain infection control measures when taking care of patients with diarrhea, including the use of gowns and gloves. That is it for my presentation. I know that was pretty verbose and repetitive, but I'd be surprised if everybody watched every single second of that. But I think that at some point it has a lot of good information in it. I think watching it could be really helpful because it is obviously a very common diagnosis that we're going to see in our future. So just knowing the disease process and ruling out other diagnoses, I think will be really helpful. And I hope you guys liked it. Thanks.